All right, great. So next, we have Dr. Mindy Christianson, and she is going to talk about how to prevent passing on the neurofibromatosis disease to future generations. So thank you. So we'll hear from her next. Thank you.
Hello, good afternoon. My name is Mindy Christianson. I'm the section head of reproductive endocrinology and infertility at Cleveland Clinic and the practice director of the IVF Center. And I'm really excited to speak to you today about how to prevent passing on neurofibromatosis disease to future generations. Okay, how do I advance this? Here we go. So when we look at the genetics, and this slide is about NF1, but it would also apply to NF2, there is an autosomal dominant condition caused by mutations in the NF1 gene, which is composed of 57 exons. There is a high mutation frequency, and actually about 50% of the cases occur de novo, which means they're not passed on from a parent, and there are multiple variants present within the gene. This does make it more complicated when we counsel patients about the chances of passing it on to offspring, but in general, if someone has the mutation, it's about a 50% risk of transmission to offspring. And NF1 exhibits complete penetrance, but it can be highly variable as far as the clinical features. Most of the research to date is on NF1 when we look at pre-implantation genetic testing, which I'll be focusing most of my talk on. So there are two different ways that we can prevent offspring from being affected with NF1 or NF2. One is invasive prenatal diagnostics, which means after a pregnancy has already occurred. And this could be due to, you could first do non-invasive blood test followed by typically chorionic villus sampling or an amniocentesis, where you're actually sampling cells from the pregnancy. And then the option would be to terminate the pregnancy if the fetus is affected. And obviously that is something that would be very difficult for people to have to proceed with. The other option, which is the option that I help patients with, is pre-implantation genetic testing, or PGT. So we can actually test embryos created through IVF or in vitro fertilization, and then select embryos that do not have the gene mutation, that are unaffected by NF, and they can be transferred to the uterus. So PGT is a relatively new technology in reproductive medicine. And because of that, it can be a little complicated, and there's lots of different terminology. So PGT is the blanket term for pre-implantation genetic testing. And there's several different types of PGT. The most common PGT that we perform today, in fact, about 60% of our patients choose this option, is PGT-A, or testing embryos to make sure they're chromosomally normal. PGT-M is the type of PGT that can help patients with NF, and that is testing for a monogenic or single gene disorder. And so if a patient has a mutation for a specific disorder, we can actually test the embryos for that mutation. And then the third one is PGT-SR, which is looking for chromosomal abnormalities or rearrangements. So basically, a patient that has NF, if they're going to do testing to test embryos to see if they're affected or not, they'll do PGT-M, but almost always people will also do PGT-A to confirm that the embryos are also chromosomally normal. Oops, gone the wrong way here. So what is PGT? So it's a technique used along with IVF to test embryos for specific genetic conditions before they're transferred to the uterus. And I'll be going into detail of what IVF entails, just because a lot of people aren't aware. But basically, a patient would undergo an IVF cycle, and then embryos would be created in the lab. In the lab, when the embryos are 5 or 6 days old, we would biopsy a few cells from the embryos, and then those cells would be sent to a company, a specialized genetics company, that will test for that specific mutation. The embryos which had been frozen, we would then select an embryo that is unaffected. That's what I just do. So here we go. So indications for PGTM include increased risk of offspring with a medically actionable condition. So that would NF would fall into that category. There's other indications like if someone was doing stem cell therapy, or if there was a sex-linked disorder in offspring, or to avoid passing on an unconfirmed autosomal dominant disease. So for NF, it's a serious enough condition that that would be considered acceptable to do PGTM. The Ethics Committee for the American Society for Reproductive Medicine has looked at PGTM, and the recommendation right now is that this would be for adult onset. You know, it's ethically justifiable for conditions that can be serious to affect someone's quality of life, or where there's not interventions that are effective in treating it. So PGT has only been around for about 30 years or so it's a relatively new technology. IVF itself has only been around for about 45 years. But over the last 10 years or so, there's been very rapid progression in the types of technology available, and genetic testing has gotten more and more effective and more accurate and easier to perform. And so in the early days, the testing was not as accurate as it is today. And there's a pathway of PGT technologies. It started with fluorescent in situ hybridization, followed by a few other types of genetic testing modalities, such as PCR. But today, the majority of our patients, when they do the genetic testing, it's going to be next generation sequencing, which is extremely accurate and thorough. So what does PGTM involve for a patient? If you have a patient that's interested in undergoing IVF and PGT to prevent offspring from being affected, first it does require genetic testing to confirm for the exact mutation, and that would be for both parents, so for both the sperm source and the egg source, to test for the mutation. And any other mutations that may be present. So there is extensive genetic counseling that needs to happen first, and then a fertility assessment. So the person that's undergoing the IVF should have a good ovarian reserve or a good egg supply, because we know about half of the embryos are going to be affected. And then after that, a specific probe is created by a genetics company to test for that specific mutation. And that process historically has taken a few months. Now it's down to about 4 weeks with certain companies, but there is a waiting period. And then the patient undergoes IVF with embryo creation, biopsy, and freezing, and then eventually frozen embryo transfer of an unaffected embryo. But what does this really involve? So there are some other things that are really important. So first of all, it involves the patient knowing the patient's egg supply, knowing the sperm count of the male partner, and then ideally the patient should be less than 40 years of age, ideally less than 35 years of age, because over 40, a female patient, the majority of the eggs, or over 50% of the eggs, will be chromosomally abnormal. And so it's better to do genetic testing when someone is younger. This is not an inexpensive process. For creating the probe, it may require samples from multiple relatives if it's not a de novo mutation. And the cost just to make the probe can be up to $5,000, and that doesn't include the cost of the IVF cycle. And then it does take about 2 weeks to do ovarian stimulation and egg retrieval. And then once we have an embryo that we're transferring, the chance of live birth is around 50 to 60%. So if a patient is interested and decides to proceed with pre-implantation genetic testing, she undergoes injectable medication for 8 to 10 days to stimulate the ovaries to make multiple follicles, and follicles are where the eggs grow. And then there will be a series of ultrasound visits, usually about 4 to 5 visits over a 2-week period, where we monitor the growth of the follicles and count how many follicles are growing. After about 8 to 10 days, the patient is ready to undergo what's called an egg retrieval. So this is a surgical procedure. The patient is asleep with IV sedation. We do a transvaginal ultrasound. Needle is then guided to aspirate the fluid from the follicles. Then we pass the fluid onto the IVF lab, which is typically connected to the procedure room. That day, the patient finds out how many eggs are retrieved, and then the next day, how many embryos there are. The patient will typically be discharged about 1 to 2 hours after the procedure. When we inseminate the eggs, we use a special technology called ICSI, or intracytoplasmic sperm injection, where we inject the sperm into the egg. We do this to prevent contamination of genetic material from multiple sperm on the egg and subsequent embryo. We expect the fertilization rates to be around 70 to 80% when we do ICSI. And then the next day, our embryology team will see how many embryos there are. This is an embryo that's 1 day old. It's called a 2PN or 2 pronuclei. This is actually a 1-cell embryo. It has a set of DNA, though, from each parent. And then at this point, we have the embryos in a special culture media that has all the nutrients they need for 5 or 6 days, and we leave them undisturbed. We're able to check on them with a special microscope called an embryoscope, and we watch the embryos grow. And what happens is the cells just start to divide. And so this is what's called a cleavage stage embryo. You can see there's 6 cells and then 8 cells. The embryos just keep on dividing. And by about day 5, 6, or 7, about 50 to 55% of the embryos will make it to the stage that's called the blastocyst. This is the most advanced stage of embryo that can grow in the lab. And it's at this stage the embryo has about 150 to 200 cells. And so then what we do for patients undergoing PGT is our lab will do an embryo biopsy. So this is a very technically challenging procedure to do. So we have our most highly trained embryologists perform this procedure. We use a laser to make a small hole in the outside of the embryo, and we biopsy a few cells. We then freeze the embryos, and then we send the cells, and the embryos are numbered to special genetic testing companies that will then test for that specific mutation for each embryo. Then they'll also test to make sure the embryos are chromosomally normal. About 3 to 4 weeks later, once the results are in, we meet with the patient, we review, and hopefully we have some unaffected embryos to transfer. But it's unfortunately 50% of the embryos are typically going to be affected, and then about 30 to 40% will be chromosomally abnormal. So it really is important to have a good number of embryos to test. So there was one large study that was done that has been reported looking at about 20 years of experience for pre-implantation genetic testing for NF1. So this study took place, it involved 140 couples between 1997 and 2020. So during that 20-year period, the technologies have improved a lot. So we really need to keep that in mind because pregnancy rates would have been lower earlier. But basically of the couples that they saw considering PGT, 43 opted out for various reasons. 15 were not eligible because they couldn't find the actual gene mutation or they didn't meet criteria for IVF. And so there were ultimately 82 couples that proceeded with genetic testing. So overall, there were 295 embryos created among those couples, and 174 were unaffected. And the end result they reported was 42 ongoing pregnancies, so a pregnancy rate of around 24%. That is definitely on the lower side for what we see today, but technology has really increased a lot or improved a lot in recent years. And so today we expect the pregnancy rate to be around 50 to 60% per embryo. What's interesting when we look at this study is that they did do fertility evaluations before IVF treatment, and it showed a greater incidence of male infertility among men with NF1 compared to the partners of affected women. So I think that that's something to keep in mind if you have a couple that wants to, if a couple wants to do IVF with genetic testing, to have a full evaluation sooner rather than later. And then also what was important, because there was a concern about the risk of pregnancy, is that cardiac assessments in women with NF1 indicated no contraindications for IVF treatment or pregnancy. Now granted, this was not all of the women underwent a cardiology assessment, that of those that did, though, there was no contraindication. And when we looked at the clinical outcomes, about 80% of the embryos had a diagnosis. So that means of all the embryos tested, 20% they didn't have a result. Today we see that about 5 to 10% of the time, but it is frustrating that so not all of the embryos will have a result. And then about 50% were unaffected, as we'd expect to see in an autosomal dominant mutation. So some other things to consider when we're looking at pre-implantation genetic testing for patients with NF, and that's IVF coverage. So IVF, unfortunately, is very expensive. The average cost for an IVF cycle is around $20,000, and then the cost of the medications can be $5,000 to $7,000. Some states have state mandates for IVF coverage, which will make treatment more accessible for patients with NF, but not all states do. In fact, only a handful of states do. So currently, about 15 states have mandates for insurers to cover some infertility services, and a smaller amount actually have like state mandates for IVF coverage. And so that can make a huge difference for access to care for patients. There's actually a study that was done that looked at state mandates and the chances of people undergoing PGT, and they did find that PGT was less likely to be performed in states with mandates with insurance coverages and those without mandates, and so it was less likely to be performed. And so actually what they found was that if there was a state mandate, it was more likely that people would undergo PGT. So in conclusion, PGT-M is a rapidly evolving technology that can help people with NF prevent offspring from having the condition. It does require IVF, which I reviewed as a time-intensive process that can be expensive, but it can be highly effective as well. And it requires creating embryos. The female patient should have a good egg supply and insurance coverage or financial means to cover the cost of the treatment. It does not appear to increase the risk for patients with NF undergoing the stimulation or the pregnancy. And if someone has an unaffected chromosomally normal embryo, the live birth rate is about 50 to 60%. Thank you so much for your attention. I'm happy to answer any questions.